The subcommittee will come to order. The chair will recognize himself for an opening statement. In this, the sixth hearing of our 21st Century Cures Initiative, we are examining continued evidence development and communication of information regarding treatments and cures in the real-world setting. Discovery of the risk and benefits of a drug or treatment does not end with FDA approval or clearance. It is often just the beginning of learning about different uses for drugs and devices, for different indications, conditions, and populations. Treatment in the real world also brings out additional information on safety and efficacy, and ensuring that this knowledge is shared widely among providers, patients, and researchers is critical. As a result, the ability of patients, physicians, and developers to communicate effectively is so important for the future of cures in this country. Unfortunately, many of the witnesses and participants we have had before us since the Cures Initiative began have raised concerns regarding barriers to communication and evidence development. This hearing is a direct result of the feedback we've received from patient groups and other interested parties. As today's witnesses will discuss efforts to limit off-label use among the provider community, limitations on communication found under HIPAA, and the Physician Sunshine Act are just a few of the barriers to 21st century cures that have been raised with us over the past few months. It is my hope that this hearing allows the members an opportunity to consider those potential barriers and the role they play in our healthcare system. With that thought in mind, I'd like to thank all of our witnesses for being here today, and I'll yield the balance of my time to Dr. Burgess, Vice Chairman of the Subcommittee.
Thank you, Mr. Chairman. I too want to welcome our witnesses. Certainly look forward to hearing from them today. And I appreciate the continued series of hearings on the 21st Century Cures initiatives. Certainly looking forward today to exploring the role that healthcare providers, physicians can have in increasing communications between patients, researchers, and those who innovate. Different uses for therapies are constantly being discovered through information highways, including social networks, patient advocacy groups, and physicians sharing information. There is no doubt that technology and the ability to communicate easily with people all around the world will change how we conduct research, how clinical trials are managed, and how the post-market surveillance of therapies is handled. We must recognize this fact and be open to rethinking the traditional means of how we have engaged with our patients. We must also rethink our expectations of the ease with which patients may engage with each other. The fact of the matter is, if I get on a plane with my iPad, I've got the New England Journal, I've got the Journal of the American Medical Association, and I've got the most current Journal of Obstetrics and Gynecology with me, and it's simply a matter of opening it and reading while on the plane. The ability to keep up with rapidly changing and evolving fields is unlike anything anyone has ever had in the past. So this is the world in which we live today, and we need to be open to realizing the benefits that can be drawn from this fact, and also recognize that while we are exchanging information, patients and patient advocacy groups are likewise engaged. So we'll certainly look forward to a lively discussion with the panel today. Mr. Chairman, I'll yield back the time.
Anyone on our side seek time? Vice Chair, Ms. Blackburn.
Thank you so much, Mr. Chairman, and to our panel, I want to welcome each of you. There is so much that is going on in the field of healthcare informatics, and Dr. Burgess just touched a little bit on that, and also medical devices. We're going to hear from Edwards Life Sciences about a heart valve which was approved in 41 countries before it was approved here in the U.S., and this is something that is unacceptable. And when you look at the length of time that it takes to get these medical devices through the FDA's process. In Memphis, Tennessee, my home state, 1 in 4 jobs is dependent on medical devices. And when you look at what is happening in the Nashville area with healthcare informatics, you realize the importance and the increasing importance of that as an economic development sector to our state. I think it is imperative that we provide a 21st century regulatory framework for 21st century technology, and a framework that is going to encourage innovation while providing safe, effective, and new therapies. And with that, I yield back.
Chair, thanks, gentlelady. Now filling in for the ranking member, Mr. Pallone. Mr. Green of Texas, 5 minutes for opening statement.
Thank you, Mr. Chairman, and thank you and the ranking member who will be here shortly on this continuing series of hearings on the 21st century cures. This is really what our health subcommittee should be about, how we can help. And following my colleague from Tennessee, although I didn't know that many jobs in Memphis were for medical, I thought it was just barbecue, but or Graceland.
If the gentleman will yield, it's because
Briefly.
of the barbecue that we need the medical construct.
Well, as you know, there's a difference between Tennessee and Texas barbecue. We like beef.
I would ask the gentleman to yield again on that. You know, there wouldn't be a Texas if there weren't Tennesseans to teach
Well,
how to
and
cook.
I can't disagree with that, because frankly, we got all the rebels from Tennessee and helped us win independence in Texas. But with that, I'm going to yield the balance of my time to my colleague, Congressman DeGette from Colorado.
Thank goodness. Mr. Chairman, I really want to thank you for holding this next hearing in the series on the 21st century cures. I've got to say, I was around my district all weekend, and everybody I talked to, from the Jefferson County Economic Development Team to the telephone town hall meeting I had last night, to the OFA people, everybody was excited to hear about this bipartisan effort that we're having, and I'm excited too. Throughout all of the previous hearings and roundtables that we've had on all of these topics, we've already learned a tremendous amount about what role Congress should play in helping to further advance and accelerate treatment and cures. Today, the witnesses will talk about examining barriers to ongoing evidence development and communication. The potential areas for discussion are far-ranging, to say the least, but I'm looking forward to hearing some specifics from the witnesses on the potential benefits of enhanced data collection and improved maintenance and secure sharing of data and information. These types of evidence development and communication can and do play essential roles in the drug and device development and approval processes, as well as in reimbursement determinations. For example, how can we take advantage of data and information to more effectively identify patients for clinical trials that are relevant to their individual disease or condition? How can we harness the data and information collected during clinical trials? What about information after the drug or device is introduced into the market? And how do we effectively utilize this information while maintaining a high standard of privacy protections? On the reimbursement side, how is Medicare's coverage with the evidence development process currently being used? And how can we improve these processes to be clear? Just to talk for a minute about some of the things that are going on in terms of evidence sharing and data. Mr. Burgess talked about taking his iPad on the airplane, and I just literally got off the airplane from Denver, where I was reading this article from the New Yorker this week. Maybe some of you have seen it. It's about a family who has a child with a very, 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 very rare genetic disorder, NGLY1, and they finally got it diagnosed, but they didn't think anybody else had it until the dad, who is a computer professor at the University of Utah, wrote a blog which went viral and everybody read about it. And the upshot is that they've now identified patients with this genetic disorder around the world. They've all met. They've put together a research consortium. They have people doing research and writing a paper to be published in a scientific journal, and they're on their way to try to figure out what they can do about this very, very rare defect. These patients did this on their own because they were sophisticated parents. So what I'd like to know is, what can we do to harness this in a much more systemic way so that these types of communications can occur effortlessly, both within the United States and with our colleagues around the world. So all of these are important questions. I really look forward to hearing the testimony today and to learning about these topics. Thank you very much, and I yield back.
Chair, thanks, gentlelady. Now recognize the ranking member of the full committee, Mr. Waxman, 5 minutes for opening statement.
Thank you very much, Mr. Chairman. Today, we have an opportunity to learn more about several issues that were raised at our previous meetings on the 21st Century Cures Initiative. From the first roundtable discussion that kicked off the initiative, we heard that FDA and NIH are leaders in driving and using advances in molecular medicine and digital technology to help get new cures to patients more quickly. They have also made great strides in improving and streamlining procedures for conducting clinical trials and in reviewing innovative new drugs and medical devices. However, we also heard about impediments that stand in the way of researchers and companies making full use of these advances. While patient registries can facilitate enrollment in clinical trials and help researchers find new research avenues to pursue, many believe more can be done to encourage their development and use. Electronic health records can help physicians and sponsors identify patients for clinical trials and evaluate the effects of drugs already on the market, but privacy concerns are limiting their use. And although FDA has shown an increasing willingness to accept data from smaller clinical trials, the more limited data generated to support FDA approval may not be adequate for coverage decisions by Medicare or private insurers. I look forward to hearing more about these barriers and what can be done to address them. We should remember, though, that we have a review and approval system that is already working quite well. It has led to enormous breakthroughs and coverage of cutting-edge drugs and devices. FDA reviews and approves drugs faster than any other regulatory agency in the world. NIH and FDA are world leaders in clinical trial design and in integrating the newest science into their policies and approaches while protecting the health of the patients. And Medicare has demonstrated flexibility in its national coverage determinations so that beneficiaries can access these new cures. I have a great interest in fostering greater access to innovative drugs, devices, and health services. But I also know that access to new innovative medicine alone will not increase the quality and outcomes patients experience in our healthcare system. Incentives must be in place for providers to furnish high-quality care to the right patient at the right time in the right setting of care. The Affordable Care Act was a major advancement in meeting these challenges, but we still have work to do. In particular, we should enact the delivery reforms contained in our bipartisan SGR legislation. We can make another great stride forward if we can send this legislation to the President's desk before the end of this year. I have a little time left, and I'd be pleased. Anybody on our side want it? If not, I yield back the time, and let's hear from the witnesses.
Chair, thanks to gentlemen. As always, members' opening written statements will be made part of the record. We have one panel today with 5 witnesses. I'll introduce them in the order of them making their presentations. First, Dr. Josh Rising, Director of Medical Devices, the Pew Charitable Trust. Dr. Louis Jock, Senior Vice President, Chief Clinical Officer of ADVI. Mr. Michael Musalim, Chairman and Chief Executive Officer of Edwards Life Sciences Corporation. Dr. Gregory Shimizi, Co-Founder, Carolina Arthritis Associates, PA. And Ms. Mary Greeley, President, Healthcare Leadership Council. Thank you each for coming. Your written testimony will be placed in the record. You'll each be given 5 minutes to summarize your testimony, and at this time we'll recognize Dr. Rising, 5 minutes for his opening statement.
Chairman Pitts, Ranking Member Pallone, members of the committee, I thank you for the opportunity to provide testimony. My name is Josh Rising. I'm a physician and Director of Medical Devices at the Pew Charitable Trusts. We have an exciting opportunity today to talk about the future of healthcare, a future where we can harness electronic data to improve patient care. advances in technology offer a potential for new approaches to develop medical evidence through a continuous cycle that begins before a product is approved and continues as the product is used by patients. As we move toward this total life cycle approach, we must consider two important issues. First, we know that clinical trials are the largest contributor to the cost and length of product development. We need to use new approaches to decrease their length and cost without doing away with these trials and the critical data they provide. Second, we must have the tools necessary to quickly and efficiently identify problems with approved drugs and medical devices and to assess their performance in real-world settings that can be different from clinical trials. We are at a key turning point. Electronic health records today collect more data on patient outcomes than we've ever had, but we are failing to realize that potential. One important innovation to harness data from electronic health records is the registry, large databases that collect information on groups of patients treated for a particular medical condition. Now imagine if we could conduct clinical trials for a tenth of the current cost. This is precisely what physicians in Sweden recently did using an existing registry. They studied heart attack prevention in more than 7,000 patients, comparing two different procedures. The data were drawn from electronic health records, and the trial cost only $300,000, or roughly $50 per patient. Conducting such a study outside of a registry in the United States would cost hundreds of millions of dollars, if not more. We can do this in the United States, too, but only if we fix the lack of interoperability among electronic health records and streamline certain electronic administrative processes. Second, just as important as ensuring prompt access to new cures is the ability to detect problems with drugs and medical devices on the market and assess their performance in real-world conditions. Here, too, registries can help. For example, an Australian registry of artificial joints found that one type of metal-on-metal hip failed at a rate more than 2 times higher than conventional hips, ultimately leading to a worldwide recall of the device. Detecting such problems earlier is vital for patient safety and could save our healthcare system vast sums. Pew will soon release a report on registries, produced in partnership with the Blue Cross and Blue Shield Association and the medical device safety group MD-EpiNet. In this report, we recommend steps to deliver timely, actionable information from registries to all stakeholders, including the public. Now, there are other ways that electronic data can also improve patient care. One is better use of the brand new Unique Device Identifier, or UDI system, which was created by FDA at the direction of Congress and will result in a unique number assigned to nearly all medical devices. If we now incorporate this number into insurance claims, we can use FDA's Sentinel system to assess device safety problems, the same way we do for drugs. Incorporating UDI into claims will also provide payers, such as CMS, with the necessary data unavailable elsewhere to evaluate outcomes for patients with implanted medical devices. Adding a UDI field to claims has generated support across healthcare, including from hospitals such as Geisinger and Mercy, health plans like Aetna, physician societies, including the American College of Cardiology and the Society of Thoracic Surgeons, as well as patient and consumer organizations. Additionally, HHS Secretary Burwell articulated the benefits of adding UDI to claims during her Senate confirmation process. New mechanisms to collect data both prior to and after FDA approval can help facilitate faster clinical trials and ensure that any problems are promptly detected. Congress should work with the administration to maximize the potential of these new data sources to ensure patient access to safe and effective medical devices. Thank you again for the opportunity to testify, and I welcome your questions.
Chair thanks the gentleman. Now recognize Dr. Jock for 5 minutes for opening statement.
Chairman Pitts, Ranking Member Pallone, and members of the subcommittee, my name is Louis Jacques From October 2009 through February 2014, I was the director of the Coverage and Analysis Group at the Centers for Medicare and Medicaid Services. I was the division director in that group from June 2004 until 2009. We implemented coverage with evidence development and the FDA CMS parallel review pilot initiative. We also revised CMS regulations pertaining to Medicare coverage in FDA-approved investigational device exemption clinical trials and executed a memorandum of understanding between FDA and CMS. CMS experience over the past decade is illustrative of the challenges to the wide adoption of certain innovative technologies. One, there are innovative products and services that do not clearly fall within the statutory scope of the Medicare program benefit. Two, the available evidence at the time of initial marketing may not clearly establish the clinical value of a new technology in the relevant beneficiary population. Three, historic coding paradigms can be uninformative to the extent that the insurer cannot identify the specific item or service for which it is paying. This blind buying creates reluctance among insurers and hampers the establishment of brand value for higher performing technologies. I believe there are opportunities. External stakeholders have requested more opportunities for coverage with evidence development and FDA CMS parallel review. While these programs were articulated in the early 2000s by a prior administration, both are included in the 2012 White House National Bioeconomy Blueprint. Since 2009, CED has essentially replaced non-coverage in final national coverage determinations, thereby furnishing Medicare coverage when it would otherwise have not been available. By contrast, in the 5 years before 2009, almost half of all national coverage determinations ended with non-coverage. Unfortunately, CMS's ability to furnish CED is limited. CMS initiates CED under ARC's statutory authority. CMS implements CED through the formal national coverage determination process. Due largely to staffing cuts, the annual number of NCDs published has dropped from approximately 12 to 13 in fiscal years 2007 and 2008 to only 5 in 2012 and 6 in 2013. Current staffing is approximately half of 2007 levels. Under parallel review, both FDA and CMS maintain their separate standards. I have no reason to believe that either agency has toughened its process as a result of parallel review. While the structure of the pilot contemplates the possibility of a national coverage determination, parallel review does not inherently require that CMS undertake the NCD process. The content of the parallel review engagement depends on the product's development stage. Ideally, early discussions with CMS could result in more persuasive pivotal trial evidence that leads local Medicare contractors to uniform coverage. Results to date are encouraging. One product received unanimous yes votes and positive comments at its recent FDA panel meeting, which the company credited to the discussions with both agencies that informed the design of the pivotal trial. CMS does not have sufficient staff to match FDA's bandwidth on potential parallel review candidates. Despite interest from device manufacturers, the parallel review pilot has been limited to only 2 products. In conclusion, CMS review of clinical trials serves 3 goals. First, it provides important financial support for innovation. Second, the sponsor can obtain CMS feedback on whether the initial trial design could persuasively inform a coverage decision. Third, CMS can inform the sponsor of existing coding or payment paradigms that may apply to the product. The current vehicles for coverage in clinical trials are unnecessarily siloed, preventing the publication of an integrated, comprehensive policy. I believe this could be fixed with small changes in statute. The definition of a local coverage determination could be revised to align LCD authority with the actual scope of local contractor claims processing responsibility, thereby enhancing transparency and predictability. As an alternative to non-coverage, some stakeholders have expressed interest in new payment paradigms for early-stage devices with immature evidence bases. Acknowledging the challenges of the federal administration budget, stable funding sources should be considered for these initiatives that are expected to produce downstream benefits. Their investment requires funding that is more predictable, potentially from the Medicare Trust Fund itself. Thank you for the opportunity to share my thoughts, and I would be happy to answer any questions.
Chair thanks, gentlemen. Mr. Musalim, you're recognized for 5 minutes.
Yes, thank you very much, Mr. Chairman Pitts, Ranking Member Pallone, Congresswoman DeGette, and members of the subcommittee. My name is Mike Musalim. I'm the chairman and CEO of Edwards Life Sciences. I'm truly honored to join the other panelists today to discuss the path to revitalizing medical device innovation in the United States. I and the other employees of Edwards Life Sciences, from our engineers to our valve assemblers, share a passion for helping patients. I'm privileged to lead a company that's the world leader and has been for 50 years in heart valve replacements. The reason I'm here is that I'm worried about innovation in the U.S. and that it's suffering from increasingly costly and cumbersome and risk-averse culture in our regulatory and payment systems. Our recent experience with a transformative therapy to heart valve replacement patients gives us a unique perspective on the current climate. In short, Edwards technology allows a heart team to deliver a collapsible prosthetic valve through a catheter into the body to avoid cracking the chest, stopping the heart, and avoid that long and painful recovery that goes along with that open heart surgery. This has become the most extensively studied heart valve ever, including an unprecedented 4 New England Journal of Medicine articles that demonstrated a triple win, which is a substantial and sustainable clinical effect, cost effectiveness, and extraordinary quality of life improvement. We appreciated a productive relationship with Dr. Jeff Shuren and FDA, as well as Dr. Patrick Conway and his colleagues at CMS, whose approach ensured that there was a balanced and reasonable process for this transformative therapy. Also, in a remarkable effort of groundbreaking collaboration between medical societies, regulators, and other stakeholders, we built a comprehensive clinical evidence and quality measurement tool for this therapy called the TVT Registry. But there's room for improvement. We all know the path to approval and reimbursement is not easy, and it should not be. Yet, the U.S. approval of this American technology trailed Europe by 4 years. We're pleased that the FDA leadership viewed this delay as a catalyst to improve, and we see several opportunities to remove barriers. I'm going to focus on 3. Number 1, evidence development mechanisms can be improved to reduce costs and delay. FDA has recently proposed a number of improvements to the pre-market clinical trial process and the post-market surveillance process that hold the promise, and these have been discussed at this committee. In my view, when registries are done right, they can yield extremely useful information about patients' outcome and device benefits. However, the benefits and the clinical and scientific benefits of registries must be balanced with the potentially significant cost burden, complexity, and potential misuse of that data. In our case, many physicians told us it takes longer to fill out the 300 fields in the TVT registry than it does to perform the procedure itself. Number 2, reimbursement incentives need to be aligned with promoting innovation. Efforts to curb healthcare spending could have the unintentional consequence of slowing down innovation in our cost-cutting frenzy. It's imperative to recognize that medical device innovations become more effective and more efficient with time and with experience. We need a system that does not shut the door to reimbursement on day 1. In select cases, coverage with evidence development can be a tool that allows promising technologies to reach patients sooner while developing evidence to support lasting reimbursement. And finally, FDA's vision to improve the regulatory process must be accelerated. Dr. Shuren and his team have outlined strategic priorities that strike the right balance between pre-market and post-market data collection and improving customer service. We know FDA is a complex bureaucracy to manage, and our leaders need a mandate to change more quickly. Congress could encourage FDA by providing additional support to expedite these changes and give them room to innovate. And finally, no discussion about medical technology is complete without understanding the true impact that they have on patients, and we meet a lot of patients. To mention one, Lester Tenney, a true American hero, part of our greatest generation, survivor of the Bataan Death March and a Japan POW, had long sought an apology from the Japanese government on behalf of fellow soldiers. Unfortunately, just as this apology was agreed upon, he was diagnosed with disabling and inoperable aortic stenosis. He wouldn't survive long, let alone long enough to make this trip. The good news is that Lester received an Edwards transcatheter heart valve, was able to travel to Japan, get the apology. This would not have been possible even 5 years earlier, and he remains vital to this day and dedicated to helping veterans. Lester, tens of thousands of other patients we've had the opportunity to help remind us every day that our work is personal and impacts people individually. Thank you for the opportunity to testify today.
Chair thanks the gentleman. Dr. Shimizu, you're recognized for 5 minutes for an opening statement.
Chairman Pitts, Ranking Member Pallone, members of the subcommittee, and honored guests, it is a distinct honor to be here today and testify before you. My name is Gregory Scamitzi, and I'm testifying before you as a member of the Board of Directors and past president of the Coalition of State Rheumatology Organizations, or CSRO. And I'm also a private practice rheumatologist at the Carolina Arthritis Associates in Wilmington, North Carolina. The CSRO appreciates the opportunity to share our views related to barriers to ongoing evidence development and communication transparency. Specifically, I will focus on situations in which valid communication pathways are being hampered by outdated practices of the Food and Drug Administration, or FDA, as well as touch upon some unintended consequence of the Sunshine Act, or open payments as implemented by the Centers for Medicare and Medicaid Services, or CMS. The FDA does not allow pharmaceutical companies to actively distribute key clinical information, even if it is related to the on-label indication, unless it is explicitly referenced in the package insert of that product. By limiting the sharing of information, physicians are hampered in their ability to gain all of the firm scientific rationale and medical evidence needed to treat patients. So that clinicians may be better informed, the CSRO urges the FDA to develop standards for qualifying real-world data through a public process, to expand the current process of review of materials beyond what is included in the package insert, to also cover other key data such as subpopulation, pharmacoeconomic, or comparative cost data, and to ensure a timely review process for such information. As part of the Affordable Care Act, Congress required the administration to set up a process by which transfers of value from certain covered entities, primarily manufacturers of drugs and devices, to physicians would be reportable. Such reportable information would then be made publicly available. The overall goal of this transparency is to make particular potential financial conflicts of interest more transparent. However, there are still considerable problems with the current implementation of open payments, including the lack of guidance and clarity regarding the physician registration process, as well as the review of dispute process lacking necessary protection for physicians. Finally, a recent CMS proposed rule related to open payments would severely hamper the flow of information. Therefore, the CSRO respectfully requests that CMS provide additional provider-specific guidance for the registration process and adopt policies that allow for flexibility of enrollment requirements so that physicians struggling to enroll remain able to participate in a meaningful manner. Ensure an impartial process for disputing the accuracy of financial information intended for public disclosure. Take steps to enhance the fairness and accuracy of the program by ensuring that healthcare providers have access to meaningful mechanisms for limiting the distribution of disputed information, and reconsider its proposal to eliminate the continuing medical education exemption and instead appropriately expand the list of certified CME accrediting or issuing agencies beyond the 5 currently cited in regulation. As I hope I have outlined today, current practices at both the FDA and CMS may be inappropriately hampering the exchange of information, making it difficult for physicians to receive the information they need to make valuable treatment decisions. For the FDA, I hope that Congress will examine ways to allow for more proactive changes among clinicians with appropriate safeguards to assure that such information is truthful and not misleading. For CMS, I hope that Congress can urge specific programmatic changes to make the transparency process accurate and appropriately descriptive of the financial relationships among the various entities. Thank you once again for allowing me to speak today and to consider my comments today, as well as the other information captured in my written statement. The Coalition of State Rheumatology Organizations looks forward to working with the committee to address these issues. I look forward to your questions. Thank you very much.
Chair thanks the gentleman. And now, Ms. Greeley, you're recognized for 5 minutes for opening statement.
Mr. Chairman and members of the subcommittee, thank you for the opportunity to testify this afternoon. And thank you as well for the attention you're bringing to the future of American healthcare and the ability of the healthcare system to develop, communicate, and utilize the data that can lead to 21st century cures. I'm here today representing the Healthcare Leadership Council, a coalition of leaders from all sectors of American healthcare. I'm very proud that our membership includes innovators like Mr. Musallam, also on today's witness panel. Our members share this committee's goals for a healthcare system that is affordable, sustainable, and of the highest attainable quality, and that is also on a path toward curing the diseases and illnesses that cost us far too much, both in lives and resources. Each year, those involved in all aspects of healthcare generate literally trillions of decisions, communications, interventions, consultations, treatments, therapies, and clinical trials. The key to achieving progress lies in harnessing this massive amount of information and setting policies and practices in place to productively share and to use this data. HLC members have been engaged in this challenge for some time, both as individual innovative companies and collectively. What I share with you today is our broad-based, multi-sector perspective on how we can create an environment in which data can be used to strengthen the entirety of the healthcare continuum. There are 3 areas where I will focus my comments today. 1, the role of the HIPAA privacy law. 2, the need for federal data policies that enhance access to information to enable health system improvements and accelerated medical research. And 3, the potential impact of the new Sunshine Act on the physician industry collaborations that are critical engines of healthcare advancement. On the first point, the HIPAA privacy and security laws are generally serving patients and the healthcare system well, and should continue to be the guiding rule regarding the appropriate and effective use of patient health data. There are certain aspects of HIPAA, however, that warrant continuing review and discussion. We need to keep in mind that HIPAA was created at a time in which policymakers weren't thinking about the knowledge that could be gained by accessing data residing in large databases and the technological ability to process that data very rapidly. It may be necessary to adjust the authorization components of HIPAA to ensure the data can be used effectively for research. Also, in order to transmit data and collaborate in its use, we need to review the utility of having 50 separate sets of state privacy laws and regulations instead of a single national standard. On the issue of federal data policy, Healthcare Leadership Council members have developed a set of consensus, multi-sector principles on data policy that I've submitted for the record. One of these key principles is our belief that access to federal health data should no longer be denied to entities perceived to have a commercial interest. The profit status of an organization should not take precedence over the larger question of how best to conquer disease and improve population health. Any standard that restricts access to critical, federally held health data is in fact detrimental to our shared goals for medical and human progress. We must put the benefit to patients first. Finally, we believe strongly that Congress must diligently monitor the impact of the Physician Payment Sunshine Act. This is not a criticism of transparency, which our member companies practice and HLC strongly endorses. We are concerned, though, about the transparency without context. We're concerned that physicians may feel stigmatized by the federal reporting of their interactions with manufacturers in a way that does not communicate the patient benefits of such collaborations. Some of our member companies are already witnessing physicians withdrawing from collaborative activities, which can have a devastating impact not only on innovation, but also on product efficacy and safety. Congress should monitor the implementation of this law to ensure that both transparency and innovation are fully achieved. Mr. Chairman, thank you again for the opportunity to testify today. We believe that this committee's bipartisan vision for 21st century cures is an achievable reality, one that can be accelerated by creating a pathway for the productive use of data that we already possess. Thank you, and I would be happy to answer any questions.
Chair, thanks, gentlelady. Thanks all the witnesses for their testimony. I'll begin questioning and recognize myself 5 minutes for that purpose. We'll start with you, Dr. Scamizzi. Different uses for FDA-approved drugs and devices are constantly being discovered, many times for treatment of different conditions and diseases or for different patient populations. Manufacturers of these products have access to robust data sets and information that is not always limited to the specific indications listed in their package inserts. Why is it important that we responsibly allow providers to have access to such information to ensure that the most appropriate treatment options are being considered?
Well, thank you, Mr. Chairman. We see, in rheumatology, we see many patients with rare diseases and unusual autoimmune problems. And we also see patients who are referred to us by other specialists for autoimmune problems in their specialty that they don't know how to handle, so they send them to us. In our armamentarium of medications, we have an array of medications that work very well. Some of them are of low toxicity and some of them are of high toxicity. In the event of a new agent being brought to the United States medical arena, having a high safety profile, but lack an indication for an orphan disease or a critically important problem in another organ system, like the eye, for example, use of those medications would be a miraculous and have a high margin of safety if we had access to information. I'm just using the eye as an example. There are other instances as well. Primary muscle disease is another one. Medications are available, but the indications aren't there, and they probably never will be, because the numbers of patients who have these diseases is so small, it would take many years to discover that the indications were there, and millions of dollars, perhaps tens of millions of dollars, to identify that. So if we had access to information that these new medications might be effective in certain other small diseases, and that may have been gleaned from the data that was derived from the direct clinical trials, then that would be extremely helpful to us and help guide us in a direction that would increase efficacy and increase safety and maybe even decrease cost and poor outcomes.
Do you believe that the current restrictions on off-label communications are limiting healthcare professionals' ability to provide the most appropriate treatment to patients, and if so, what needs to happen?
And what was the last part? What was it?
If so, what needs to happen?
Yes, I do believe that the limitation of exchange of information is hampering the delivery of health care to some of these patients, especially in my subspecialty. What needs to happen is that we need to have access to information that's locked up in vaults in pharmaceutical companies and locked up in data sets in study information. For instance, here's a great example that I can spread to rheumatology. There's a great drug that came out many years ago to prevent ulcers and to treat ulcer disease and esophagitis called Prilosec. The generic name was omeprazole. Prilosec was a mixture of two different mirror image molecules, a D enantiomer and an L enantiomer, like a right hand and a left hand. Well, it came to light that one of the enantiomers was much more effective at treating ulcer disease and esophagitis. So out came esomeprazole, or Nexium, which has proven to be much more effective. What if there were medications on the market right now that we have that could treat diseases but have side effects? And yet, if we isolated the D enantiomer and the L enantiomer, we would identify which one was effective and which one caused the problems. I submit to you that there are drugs in our compendium right now that have D and L isomers, and the data sets are probably available in the vaults of pharmaceutical manufacturers that show the D isomer is more effective than the L isomer. The L isomer has more complications than the D isomer. So that would be a dramatic improvement. So such data sets are locked up. We don't have access to them, and I don't know that we ever will.
Quickly, Ms. Greeley, you mentioned HIPAA. What kind of changes should we consider to HIPAA to ensure that big data can be used effectively for research purposes while still protecting patient privacy?
Well, when the HIPAA law was originally passed, there was an exemption for healthcare operations, and that included the treatment and payment for patients, but sort of outside that scope was research activity. So I think a very simple approach would be, let's include healthcare research as if it is a natural part of healthcare operations. There are probably several other recommendations that we could make, but I think the key here is to make sure that we have an appropriate balance between protecting patient information, and we believe very strongly in that. We also don't want to erect barriers to having access to that data. I think a big part of this is having informed consumers, educated patients, and especially as we're seeing patients engage more and more in the management of their own health care.
Chair, thanks, gentlelady. My time's expired. Chair recognizes the ranking member, Mr. Pallone, 5 minutes for questions.
I wanted to start with Dr. Jacques, and then, if I have time, ask Dr. Rising a question. But Dr. Jacques, I wanted to better understand what you mean when you talk about the confusion created by Medicare's vague authority and lack of administrative agility in Medicare coverage and payment policies for new innovative technologies. Could you briefly describe the statutory limitations that apply to Medicare coverage determinations, both as they relate to coverage with evidence development and local coverage determinations, and what are your recommendations for how to streamline these authorities? And then maybe how does this existing authority impact the decision-making framework for CED study questions, and what data is needed to trigger an end to CED study?
The reasonable and necessary standard, which is essentially the coverage standard for Medicare, those provisions are in 1862A1 of the Social Security Act, which is then followed by subsections A through P that parse things out for prevention, hospice, and things along those lines. CED itself is not defined in the Social Security Act, so CMS has had to rely on the Agency for Healthcare Research and Quality's Research Authority under Section 1862A1E of the Act. Thus, ARC has to approve every CED decision. While the scope of a national coverage determination is described broadly in statute as a decision under Title 18, local coverage determinations are defined in the Act only as decisions under 1862A1A. Thus, an LCD could not implement coverage with evidence development. So even if there were an item or service that is only furnished within one contract or region of the entire country, a national decision would be required to implement CED. I've been told by various stakeholders that CED could be approached more eagerly if it were not tied to the formal NCD process. The current framework forces CMS to apply the CED requirement to all beneficiaries receiving the item or service in question, regardless of where they live. This is a particular challenge for beneficiaries who live in the more remote parts of the country where clinical studies don't normally happen and clinical trial enrollment is frankly unrealistic for many. A more agile CED paradigm would permit CED to occur in parallel with other forms of coverage, rather than requiring everyone to fit through the same door.
Now, you also highlight a rapid decline in the number of national coverage determinations in the last few years. How has that how has the lack of staff resources within CMS impacted that decline, and what, if any, impact has this had on coverage with evidence development?
I believe that staff reductions are the largest single cause of the decline in the number of national coverage determinations. And the impact of this decline is broader than CED because it impacts the agency's ability to respond to other requests for coverage. CED itself generally requires more internal staff work to develop, and it creates an ongoing need after the publication of the final decision to interact with sponsors who might want to conduct clinical trials. By my own estimate, it takes about 3 times as much internal effort for CMS staff to do CED than it does to simply say yes or no.
All right, thank you. I'm going to try to get this in, Dr. Rising. You note in your testimony that the TASTE trial conducted in Europe on heart attacks cost a tiny fraction, perhaps one hundredth of what it would cost in the U.S. because it was able to make use of patient registries. However, we also heard in Mr. Muslim's written testimony that registries can be very expensive to set up and maintain, and threshold questions must be answered to determine when and how registries should be used for post-market data collection. Now, I'm familiar with registries from the law creating the 9/11 health program. It included a provision to authorize a registry of people who were exposed to toxic dust from the attack on the World Trade Center on 9/11, but I don't know much about registries for assessing medical products. Can you explain how these registries work, and can you describe what sorts of impediments to the use exist, including why they may be hard or expensive to set up and maintain? And I'd like to know your thoughts on what can be done to facilitate their use.
Sure. I'd
Not
be
a lot of
happy
time to do it.
All in 30 seconds.
Okay.
So medical product registries, kind of like the 9/11 responder registry, will follow a group of patients with one exposure for a period of time. So, for example, we heard a little bit from Mr. Musalam about their transcatheter valve registry, which follows patients who have gotten a valve for a period of time in order to assess their long-term outcomes. Now, while registries can be a tremendous source of information on the post-market performance of devices, there are some barriers to setting them up. And one of the biggest barriers is the lack of interoperability between systems. So, for example, clinical staff need to enter data in the TVT registry and then enter a lot of the same data again in electronic health records. So this kind of added burden on the staff is one of the biggest drivers for why registries are currently inefficient in the United States. Now, in addition to these post-market benefits, registries can have tremendous benefits for innovation as well. One of the other benefits that we've seen for the transcatheter valve registry that Dr. Shurin talked about at the first hearing was that data from the registry was used to expand an indication for the device. So if we're able to take some steps in this country forward for registries, we should be able to see significant benefits both there on the safety side and then also on the innovation side of things.
All right. Thanks a lot. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the Vice Chairman of the full committee, Ms. Blackburn, 5 minutes for questions.
Thank you, Mr. Chairman. I've got just a couple of questions that I want to go to, and again, I thank you all for participating with us and working with us. There is a lot of bipartisan agreement on this. You have heard different members of the committee speak to that, finding a pathway forward so that we deal with a regulatory framework, provide some certainty, and speed up the process by which innovation and cures are going to get to our patients is something, it's a shared goal. So we thank you for that. Mr. Musalam, let's go back to the topic of the registry. We've talked a little bit about that, and you all have talked about basically the data and the value of the data that can be found within those registries and the benefit to patients from being able to utilize the data in those registries. So let's talk a little bit about risk that are there for the patients or cost that is there, and can you give me just a little bit of an articulation looking at the other side of this with risk and cost, both the actual dollar cost or, as Ms. Greeley mentioned, the privacy, some of the privacy concerns?
Yeah, thank you very much, Member Blackburn, and I applaud the bipartisan cooperation toward this shared goal. Registries can be a powerful tool, and we by and large think that could be very appropriately used. My only caution that I mentioned in my testimony is that there are some cases where technologies or therapies are well enough known, you can establish a safety and effectiveness standard without going through that sort of process. In the case of the TVT registry in particular that I mentioned, the large group of stakeholders ended up generating this long list of items to be collected. I mentioned 300 data fields. Maybe when a technology is brand new and unknown, you want to learn an awful lot about it. The problem is that becomes quite costly, and at some point it gets too expensive to maintain. Ideally, you'd have a registry that could be whittled down to those things that are really most critical that you'd like to measure, and maybe a way to populate it with electronic data that's already being generated, such that a registry could be a very cost-effective tool. In the case of the TVT registry, it literally costs 7 figures plus per year for that total cost. That's shared by a lot of constituents, including manufacturers, but a lot of the burden rests on hospitals. They have a burden where they actually pay a fee every year and additionally have to put on dedicated staff just to fill out those fields. So not something to be taken lightly.
If you had to give us a list of guiding principles as we look at a framework for developing some of the registries, what are those 3 or 4 principles that you would articulate?
You know, I think it's most important to have a clear risk-benefit analysis and also have clear goals set out by the registry. There should be a set of rules around the registry and some governance guidelines around it. Dr. Rising spoke to the work that Pew Foundation has done in this area. It's actually very thoughtful, done with a broad group of stakeholders about the value of registries, and I think that's not a bad guidepost.
Okay, and let me ask you this. Do you envision any of these registries moving to the point where the patient could populate some of those cells and fields themselves?
You know, ideally, registries would not be expensive to populate, and any time that they could be filled out automatically in an electronic patient record, or even, as you suggest, that a patient could do it themselves, this is important. I mean, some simple things, is the patient alive? Is the patient going through a routine of exercise, or what is the patient's diet? All these things are very potentially powerful variables that could provide insight to the value of technologies.
Well, we would hope that anybody populating one of these with an app on an iPad would indeed be alive and not have their avatar doing it for them.
Well said.
So, okay, Dr. Shimizi, let me ask you just a couple of things on the off-label use. You had mentioned that, and I'm intrigued by this. I think this is an area that could give some, it holds some promise. It's a legal practice, correct? Okay. Do you consider it a best practice to inform a patient that a therapy that's being prescribed is off-label?
I think that's best practice, yes, and I always do.
If informed doctors can legally prescribe off-label to patients who are also well-informed, what would be the current barriers to that practice?
Well, the barrier is we need the information to pick which drug to use in a difficult situation, and that information is not always available to us. You know, there are in the immune system, there are different cells that are at work, and we know that a certain cell is active in one disease, and if we can suppress that cell, we can suppress the disease or cure the disease, and that agent might be available for a cancer, but if we can transpose and use that in this patient, that would probably work. It would be very nice to have that information from the pharmaceutical company or manufacturer or innovator who developed that product, that yes, this is very, very likely an effective way to use this medicine, but we're never going to study it because they probably never will.
Okay. I will yield back. I'm over time. Thank you, Mr. Chairman.
Chair, thanks, gentlelady. Now I recognize the ranking member of the full committee, Mr. Waxman. 5 minutes question.
Thank you, Mr. Chairman. The Affordable Care Act strengthened our movement away from a healthcare system that rewards providers for the volume of services they provide and toward a system that fosters and promotes the high-quality, high-value care. The bipartisan SGR legislation, that's to make, this committee's perspective, a permanent change in the reimbursement rate for physicians under Medicare. That legislation passed out of this committee and the other committees of jurisdiction, and it furthered that aim by incentivizing care delivery that is coordinated in alignment with consensus guidelines and best practices and as efficient as it is appropriate. Dr. Jacques, in your testimony, you speak of the broad national goals of federal health agencies to improve public health and protect beneficiaries' access to products and services that demonstrate genuine benefit. You suggest that FDA approval for drugs and devices puts products on the shelves, but a prudent purchaser should not blindly pay for those products without regard to how useful or appropriate they are. Could you speak to this point? Should Medicare really be paying for products that have no real value, or paying more for products that have no added value? How do we balance the desire for rapid adoption of new technologies with ensuring that providers can be confident in the safety and benefit of new technologies as they are held accountable for their use?
New technologies remind me of teenagers, and both of my children are adults, so I've survived raising teens. We see glimpses of their future promise, but we also recognize that not all of them are going to be good drivers as soon as we put them behind a wheel. As a society, we accept this and we balance their independence with our risks through a variety of mechanisms, whether it's a learner's permit or a prohibition on consuming alcohol or driving with friends. I believe in an ideal health technology system, we would have one where lessons are learned quickly and disseminated broadly. That depends on reliable collection, analysis, and publication of real-world data that arise from use in patients who are more typical than those studied in pivotal trials and who are treated in their communities by their own physicians.
Okay. But what does that mean if a doctor wants to use a new technology and he has to be confident that this is going to be safe and it's going to benefit the patient?
I'm sorry if I was obtuse. What I was trying to convey is that the timing of calling the question is as critical as the content of the question itself. And especially for new technologies, the issue is being asked to call the question arguably prematurely, to give it a thumbs up or a thumbs down, when in fact what you actually have is an adolescent technology that has promise, but you don't really know the final answer.
And should we be paying for that through the Medicare system when we don't know whether it's going to have any added value to what we already have available to us?
There are people who feel strongly on both sides of that question, sir.
So when do we call the previous question to get their vote? Well, we hear a lot of concern raised from manufacturers on the cost of data collection to the healthcare system, both in real terms and in delays of bringing new technologies to patients. However, as you suggest, under the 510K paradigm, some devices may be cleared for marketing with no relevant clinical trial evidence at all. Could you discuss your concerns with that program and the potential risk to the healthcare system of Medicare covering such technologies even under its coverage with Evidence Development Authority?
Yes, while that paradigm is appropriate for many low-risk devices, I would focus my own attention on that subset of cleared devices where untested claims of enhanced benefit are made beyond the predicate device, or where subsequent evidence may raise questions about the fundamental impact of the technology. I think the premise of the 510K program makes it more difficult for a sponsor to articulate an enhanced value proposition for a technology when it's been found to be substantially equivalent to an old technology. And that, to me, is the critical point in terms of paying for value, that a value proposition that you are essentially better than something is hard to make if you have not actually been compared to anything else.
Mm-hmm. So we may have a 510K to get the device approved, but we ought to know before we start paying a lot of money for it that it's going to work.
Yes, sir.
Thank you. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the Vice Chairman of the Subcommittee, Dr. Burgess. 5 minutes for questions.
Thank you, Mr. Chairman. I want to thank the ranking member for his generosity in mentioning H.R. 4015, which was the repeal of the sustainable growth rate formula, which did come through this committee. We're about on the 1-year anniversary of that 51-0 vote. That was a landmark occasion for the committee. And in many ways, the development of that SGR policy was very similar to what's happening with the Cures initiative. So I think that provides a template that ultimately could speak to success for the Cures initiative. That as we opened the doors up, we took information, asked for information from physicians, from patients, and as to what they needed to see in the repeal of the sustainable growth rate. As a result, nobody got exactly what they wanted, but we got a product that was ultimately supportable by both Republicans and Democrats on this committee, and ultimately did pass the floor of the House, though we're still waiting on the Senate. Ms. Greeley, I need to ask you a question about, there's a bill that Donna Christensen and I have done, H.R. 2663, which deals with CBO scoring, because oftentimes it seems like there are good ideas that are developed within the healthcare sphere, but then CMS will say, but you know what, all we can do, or the CBO will say, CMS just tells us about the cost, so all we can do is report to you on the cost. So the ability to implement this new regimen is in fact a cost driver for the system and cannot be regarded as a cost saver. And in fact, in this committee, even though I didn't support the Affordable Care Act in this committee, I recognized a great deal of anxiety on the part of my Democratic counterparts in dealing with Mr. Elmendorf at the Congressional Budget Office. Wait a minute, we get no credit for all of the savings we're going to get from treating things in a more timely fashion. So as your role at the Healthcare Leadership Council, have you studied that issue at all?
Yes, Mr. Burgess, and we strongly support the legislation.
I felt you would say that.
You think so?
That's why I asked you.
And delighted that it's bipartisan legislation as well. But as you know, innovation plays a strong role in wellness and prevention. And what our members have seen are long-term savings when you make that investment in wellness and prevention. And as you point out, unfortunately, CBO and their traditional scoring methods does not give you credit for those long-term savings. And we know that 70 to 80% of healthcare costs today are going towards the treatment of preventable chronic disease. And we know that if we make an investment over the long term, we will see a dramatic reduction in those healthcare costs. So your legislation wouldn't mandate that CBO have this longer scoring window, but at least would have that option so that you as members of Congress could see that information and then make your decision on making those investments, which may have a short-term cost, but we know in the long term will result in better health and lower cost for the healthcare system.
Well, oftentimes it seems, you know, today we only end up talking about the cost of a therapy, and we don't recognize the fact that, my goodness, we've beaten one of the big scourges of people's health. I mean, the hepatitis C treatment comes to mind. Instead of talking about the victory over hepatitis C, a disease that didn't even have a name when I was in residency. We called it non-A, non-B hepatitis. And now there is a treatment for it that is, in fact, a cure. I mean, that's pretty big news. So, I mean, that's my hope that the Cures Initiative will be able to focus on those things. Yes, we'll talk about price and we'll talk about cost as we go through. But the big news, the headline is hepatitis C vanquished in our lifetimes, and that's a big deal. Dr. Shimizi, I wanted to ask you a question on the Sunshine Act and the Sunshine Act provision that was contained in the Affordable Care Act. It does seem like it was written pretty broadly, and now the implementation is or runs the risk of hindering communication and information sharing amongst physicians. So a rule came out over the 4th of July weekend that may prevent some of the country's most qualified physicians from giving lectures to fellow physicians through continuing medical education. Have you heard of providers that are having difficulty getting access to medical studies, or even finding it more difficult to access continuing education because of the way this law is being implemented?
Excuse me, Congressman. I don't think it's, I don't hear of anything yet, but I can certainly see it coming, that the Sunshine Act provision, the way it's written, can actually inhibit speakers from wanting to attend or be participants in a medical conference because of the information that will be published about them being paid and where the money comes from. Most institutions, most professional associations get their funding from member dues, but they also get funding from industry support that are in the form of gifts or donations. And those gifts and donations, if they're identified to be tied to CME credits, can actually impair the desire of academicians and thought leaders in medicine to give those presentations in front of those societies. So it can have a real negative impact on on that. I don't believe it's happened yet in my subspecialty, but it certainly is possible.
Thank you for that answer, Mr. Chairman. I hope that's something that this committee will keep in mind and continue to monitor as we go forward. I'll yield back.
Chair thanks the gentleman. Now recognize the gentleman from Texas, Mr. Green, 5 minutes for questions.
Thank you, Mr. Chairman, and again, thank our witnesses for being here. A central component to improving the quality of our healthcare system and developing 21st century cures must be data-driven innovation. Mr. Muslim, in your testimony, you talked about the coverage for evidence development, CED determination, how it can be usefully used appropriately. However, the challenge of ensuring CED as a tool for the reimbursement system to give patients access to groundbreaking therapies rather than burden that ultimately limit innovation remains before us. Can you tell us how we might be able to handle that?
Sure. You know, particularly the use of CED, I think, is valuable for therapies that are new and really haven't been evaluated in the past. In many cases, the therapies that can be reimbursed are ones that are well understood, and you could establish a safety and a safe and necessary threshold. But in the case where you just don't know much yet because they're novel, it's helpful to be able to apply CED. It's not always clear in the beginning of the CED process exactly what evidence is going to be collected and how much is necessary. And one of the things that's also not clear about CED is when does it come to an end? At some point in the initial stages of a technology, it's very valuable to learn as much as you can and collect that evidence, but once you've done that for some period of time, it's appropriate for CED to sunset so that it doesn't just become another layer of cost that sits on the healthcare system. And so it's important, I think, to define CED more thoughtfully and carefully as we think about using it as a tool, but it has great promise for the entering areas that are unknown.
Okay, do you have any mechanisms you would suggest to enhance the coverage of these innovative therapies?
It's not a simple question. You know, in the case of our transcatheter technology, the CED was used, and it was used that allows for this important aspect of medical device development to be evaluated. Different than a drug, medical technology is one that's an iterative process because we make tools for physicians. Often we get a lot of feedback from physicians, and they said, could you make it better? Could you make it smaller? Could you make it do things that it doesn't do today? And we respond to that. And through those changes, therapy improves dramatically. And so a coverage with evidence development tool that is flexible, and this is what was done in the case of transcatheter heart valves, allowed for the system to accommodate new generations, new indications as the evidence supported it. So that's a powerful use of that tool.
Dr. Jacques, is there any other mechanism available to provide coverage to these new innovations?
There are other mechanisms, including regulations concerning Medicare coverage for FDA-approved Category B investigational device exemption trials. The challenge being that aside from CED and those IDEs, there is not an obvious path for other sorts of valuable research.
Okay. Anyone else on the panel for those issues or those questions? If not, our entire healthcare system is shifting to a model that embraces shared decision-making by informed patients whose views are valued and considered at every stage of the treatment. We've heard a great deal about the potential value for patient preference information and regulatory risk-benefit determinations, particularly in the context of medical device pre-market approval. The FDA has emphasized that patient tolerance for risk and perspective on benefit is an important consideration. It makes sense for the innovators and regulators to consider patient perspectives as they develop and evaluate medical devices. Ms. Muslim, again, what potential benefit do you see from incorporating patient preference information in regulatory determinations? And do you have any suggestion on that could be incorporated in the process?
Sure. All medical technology and all medical advancements are not created equal. Some can have profound impact on patients' lives. In our case, sometimes it's the only difference between life and death for these patients. And when you're making that sort of a consideration as a regulator, you'd really love the regulators to have the ability to apply a risk-benefit analysis when they're thinking about what they should do in terms of allowing this technology to come to patients. If you keep the bar too high in the pre-market approval setting, what you might do is, in an effort to achieve great science, again, allow patients to not benefit and, in fact, die or live very poor quality of life. And sometimes it would make some sense to allow a certain element of risk, certainly to safeguard against safety concerns and have a basic level of evidence, but to study in a post-market setting the true depth of efficacy in a real-world setting, and then apply that and make adjustments. So this is one that you wouldn't want to be unfettered, but to give regulators, as a matter of fact, not only the ability to, but the mandate to take a risk-benefit analysis, I think would be a powerful enhancement for a system and make it a learning system rather than what we have today.
Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize gentleman from New Jersey, Mr. Lance, 5 minutes for questions.
Thank you, Mr. Chairman, and good afternoon to you all. Ms. Greeley, in your testimony, you state that the key to harnessing the potential of real-time data lies in putting the policies and practices in place that allow us to harness this data. You then go on to state the importance of protecting confidential health information while also making data appropriately accessible under HIPAA. In several of our recent hearings, witnesses have pointed out the challenges that arise in ensuring that this innovative technology is HIPAA compliant. Are there ways in which HIPAA inappropriately restricts the sharing and use of patient data by researchers and medical providers?
I think it's an ongoing challenge, and really what we're trying to do is find the appropriate balance between protecting that patient information, but not stifling the innovation or access. And so we constantly have to keep that in mind. And periodically, proposals are put forward that really would consume a lot of resources and time and really don't create any particular value for the patient. I'll use as an example of that disclosure of everyone who has had access to the patient information, whether they're within that healthcare operations that I discussed, which is reasonably expected by patients. So I think it's all about making sure that we don't try to micromanage this, and we really put the patient at the center of it, and how can we create better value for that patient. And so as we're looking at new ways and new access to information, and I'll use it as an example of that, as I mentioned earlier, patient engagement and the new tools for that, the mobile apps. And we're spending a lot of time, those of us that have been mining the HIPAA world for many, many years, working with those app developers and telling them, as you're approaching this, we don't want to hinder your innovation, but try to build into your system up front the appropriate patient protections and information protections. But again, the key is let's not stifle that innovation by them, and let's not defer a whole lot of resources that could be going towards patient care and treatment and innovation by getting caught up in too much compliance activity.
Is there something we should be doing here in Congress to make this a better situation?
I would almost say don't do too much.
First do no harm.
Yes, first do no harm.
To coin a phrase.
Yes, and as we're looking, we've heard a lot today about registries and how we can use that information. I would say, again, let's not stifle that access and the use of that information. And the other very powerful thing that we're seeing that I think is going to make all of this much more available and much more usable is what's happening with health information technology. I don't think any of us could imagine, even 5 years ago, how rapidly we're able to build these databases and how rapidly we're now able to access that information, and more importantly, get those best practices to the physicians right as they're treating the patients, and having those practice guidelines, which is going to go a long way towards creating that value that we've all talked about in our healthcare system.
Thank you. The Physician Payments Sunshine Act, usually known as the Sunshine Act, requires manufacturers of drugs and medical devices that participate in federal health programs to report payments to physicians and teaching hospitals. In your judgment, has that data sharing in this regard been beneficial to medical innovation? Ms. Greeley?
Again, I would sort of caution, and I think we heard a lot today on this panel. We all believe in transparency. We think that's important, and having the disclosures about, collaborations between physician and industry. What we're most concerned about, and what we have actually seen already, is the chilling effect. That physicians are concerned, wait a minute, this is a minimal amount of money. It is just not worth it to have my name on a list when there's no context about what was the value of that collaboration. And I think you heard Mr. Musalam talk about their interactions with physicians as they are developing new cures, new devices. It's absolutely critical. And their partnerships with academic health institutions, absolutely critical. So again, it's about balance. We think there should be, reporting this information, but it needs to be in context so that people know what is the value of having physicians working with manufacturers, and how does that benefit patients?
Thank you. My time has expired. Thank you, Mr. Chairman.
Sure, thanks, gentlemen. And now I recognize the gentleman from Florida, Mr. Bilirakis, 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate it very much. First question is for Dr. Shamizi. There are about 7,000 diseases, only 500 treatments available. Patients with rare diseases frequently have no approved treatments. This forces these patients to find off-label usage for medication to treat their condition. If the FDA has rules limiting information to doctors and patients, this could harm a patient's health. And I know this was touched on earlier. Our health system should be patient-centered type of care, in my opinion. Given that, how can we ensure that patients and their physicians have access to information, whether it be on-label or off-label usage, so that they can determine the best course for treatment?
Thank you, Congressman. I think the best way to do that is to ask the FDA or direct the FDA by legislation or statute or regulation changes to allow that communication to go forward. Right now, that communication is badly stifled, and much of the information that pharmaceutical manufacturers and innovators have is hidden from our view. Rheumatology treats many diseases that have no defined treatment. There's no medication that's defined to treat Sjogren's syndrome. There's no defined treatment, no medication specifically defined to treat chondrocalcinosis. There's some of these unusual diseases that aren't really rare. We see a lot of people with that, but we have no defined mechanism or medicine that's approved to use in these diseases. But things like Sjogren's syndrome, I'm certain that the pharmaceutical company that's manufactured some of the medications available today have had crossovers with patients who have Sjogren's syndrome, and they have data on how those patients' Sjogren's symptoms improved or worsened, which is also important to know. Did a particular medication make that particular subset of symptoms worse? Those things are important for us to know, but those things may not be readily available to us, and those would be very helpful to have.
Thank you. Would it improve the standard of care to have these indications on the label, such as ensuring correct dosage and access through insurance reimbursement? And should we incentivize sponsors to do the additional studies to get these off-label usage on label?
I think incentivization to do some of these studies on these small diseases would be very, very helpful. It took 15 years to define that dermatomyositis was treatable with a medication that's been on the market for 20 years. It took that long to get a large enough sample size to prove that the medication really worked. And dermatomyositis is a devastating inflammatory disease of muscle that destroys muscle tissue and skin. So incentivizing those types of things would go a long way. Now, National Institutes of Health already does that, and they were the ones who sponsored the actual study on dermatomyositis. But incentivizing manufacturers to go forward with some of these smaller diseases would be very helpful. Yes.
Very good. Thank you very much. Mr. Musalam, you mentioned that it was 4 years after the EU approved, before the FDA approved the Sapien Valve. Is the U.S. typically behind the EU for device approval? Why, and how can we accelerate the process?
Yes, it was 4 years difference. I would say generally in medical devices and medical technology, manufacturers would introduce their products first in Europe. The burden of proof to be able to introduce in Europe is much lower than the burden of proof required by the FDA. There's a level of safety that needs to be established in Europe, but a much lower level of efficaciousness that's required before it moves to the marketplace, and it's left to the judgment of physicians and patients and whether it should be used. The FDA requires a much higher level of science to bring it to the United States.
How can we accelerate the process here in the United States?
Well, there's several ideas, and a number of them have actually been mentioned by Jeff Shuren, who's responsible for CDRH, including trying to think more carefully and take a risk-benefit analysis and think carefully about what might be collected in a pre-market setting versus a post-market setting. If you were to have, in the cases where patients really need the benefit, if you were to have a pre-market setting that wasn't so onerous, but rather have more extensive study in the post-market setting, what you could do then is potentially speed these cures to people that really need it when in the judgment of FDA, it was the right thing to do. And at the same time, make sure that you're collecting the evidence so that therapies that are winners get supported and losers get stopped.
Well, thank you very much. Appreciate that. And I yield back, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentlelady from North Carolina, Ms. Elmers, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to our panel, especially Dr. Shimizi. Welcome from Wilmington, North Carolina, one of my very favorite places, and just down the road from Dunn, North Carolina. Dr. Jacques, I have a question for you. You state that CMS needs unambiguous authority to review clinical trials when claims related to these trials will be submitted for Medicare payment. In what ways is CMS authority in this respect limited now, and how does this impact the search for cures?
At a fundamental level, one would expect that the Medicare program or any insurance company would know what it's paying for as opposed to paying blindly. And my understanding is periodically Congress asks Medicare, how much research are you paying for? And my understanding is the agency's been unable to actually produce a number. So that would be helpful to know. I think that Medicare engagement on research would actually serve a number of purposes because I found, much to my own frustration while I was a civil servant, that there would often be times when companies would have come in with the data that they had, and we would sit there around the table going, you know, if only 2 years ago you had made this small change, it would have made a very large course direction in where you came up. So the challenge is that Medicare covers routine costs in clinical trials based on a White House executive order from the end of the Clinton administration. There is then a distinct regulation on FDA Category B investigational device exemptions, and then there is CED. And in any particular trial, there may be an overlap of those things. So CED would include routine costs, for example. There may be CED that might also be combined in the context of an FDA IDE approval study. And because all of these things are siloed, it is very, very difficult at the staff level when a prospective investigator comes in and says, okay, here's my clinical trial. These are all the things I want to do. Can you tell me if it's covered or not? And that can be a conversation that takes months to get to all the details. And I believe that if CMS simply had a singular authority that would relate to this, it could then publish an actual integrated policy where all the pieces actually fit, and you weren't running all over the place trying to find different parts of an answer.
Mr. Muslim and Dr. Shimizi, it looked like you were very intrigued by Dr. Jacques' answer. Is there anything that either one of you would like to comment on?
Yeah, we think that just by listening to comments of Dr. Jacques and others in CMS, we've heard that there are limitations to what policy allows CMS to do. And also that there's limitations associated with their staffing levels, and that's concerning to us. We're dependent on payment to be able to bring these technologies to to patients. One of the particular things that are most noteworthy is much of the great medical breakthroughs come from individuals or very small companies or somebody that just has a great idea, and being able to take that from a napkin to reality is becoming longer and longer and more costly. And to be able to have a conversation with CMS that clearly defines a predictable process would be very powerful to those organizations. It's one of this unpredictability has a chilling effect on innovation. So that kind of clarity would be very positive.
Dr. Shimizi.
I found that what Dr. Jacques mentioned about staffing problems being an issue with national coverage determinations and local coverage determinations contrasting one another or conflicting, very intriguing, especially because that's a topic that has really hit us very hard this last year when we have a patient who may live in North Carolina part of the year and New York another part of the year, they have Medicare. They may be able to get the medication in North Carolina, but when they go to New York, the medication is denied because the carrier is different and the coverage determination is different. It would be really nice to have a uniform set of rules. Yeah, I mean that's essentially what the national coverage determination was meant to do. But I can now understand, given what I've heard today, that it might indeed be staffing problem that doesn't allow CMS to act on a national level and allows individual carriers to make different determinations in different states, which makes it difficult for a patient to get the same care in different areas of the country.
Right. Well, thank you. And my time is about expired, so I will leave it at that. Thank you, Mr. Chairman.
Chair thanks, gentlelady. Now recognize gentlelady from Colorado, Ms. DeGette. 5 minutes for questions.
Thank you very much, Mr. Chairman, and thank you again for your commitment to these hearings. Mr. Muslim, in your written testimony, you mentioned some of the advantages of registries to help with post-market surveillance. And you talk about the American College of Cardiology and the Society of Thoracic Surgeons working collaboratively to create the STS-ACC-TVT registry. Can you talk to us a little bit more about that registry, when it was formed, the costs, and who can access that data and information?
Yeah, thank you. It was a remarkable collaboration, and again, the idea of routinely when a new technology is approved, FDA would mandate a post-approval study. In this case, the idea of mandating a post-approval study took a couple of forms, and an alternative was presented to collect data in a registry rather than collect more extensive data on a smaller group of people. Through conversations with CMS, as a matter of fact, this actually became one where CMS also became partners in this discussion, as well as a number of other stakeholders. It actually became part of the national coverage determination, because the national coverage determination said, we'll pay for this new procedure if you're collecting evidence. And they did that under the provisions of coverage with evidence development. So this registry became multi-purpose, and it did a few things. One is it became the post-approval study for FDA and to follow patients on a long-term basis with this new therapy, and every patient gets this, so it's a very large and powerful database. It became the tool used for evidence collection for CMS in terms of their ultimate decision-making on coverage for evidence development, and it just became very powerful to the medical community, because here was a set of data that's rather than being managed by a company.
Yeah, excuse me. They only give me 5 minutes, and I appreciate every minute of that. Who can access that data and information from that registry?
Yeah, that's exactly where I was going.
Okay.
This data is managed by the American College of Cardiology and Society of Thoracic Surgeons, and matter of fact, so it is housed within their organization, and so they have access to it. There's an advisory board that includes many of the members of those societies that actually ride herd over that data and publish results from that data on a routine basis.
Okay. Now, there are some limitations, I think, that you and others have pointed out with registries. And I'm wondering, do you think it's just because we don't have a lot of experience with it?
Yeah, I think there is concern that we don't have experience with registries. That's certainly true. We had no experience, for example,
Right.
in our field
Right.
of heart valves.
So we just need to learn. Dr. Reising, I wanted to ask you quickly, along these lines, in your testimony, you talked about the Sentinel initiative as a possible alternative or supplement to registries. Can you talk about how those can work for data collection?
Sure, I'd be happy to. Thanks. So Congress instructed FDA to establish the Sentinel program in 2007 to proactively monitor for problems with drugs and biologics on the market. And in 2012, Congress instructed FDA to expand Sentinel to include medical devices. Now, what Sentinel is it uses claims data, almost exclusively claims data housed by payers, to look for associations between exposure to a particular product and then a particular health outcome. Now, Sentinel could be expanded to devices, except that right now there's no specific information on a device that's used in care on the claims form. So a payer might have information that they did a hip replacement that they're paying for, but they have no information on the specific hip replacement that were used.
Right.
So to expand Sentinel to include devices, a new field needs to be placed on the claims form. And in general, we're a big supporter of using existing structures, such as claims forms, to capture new information like this.
And Mr. Muslim, in your testimony, you said that we need more resources and support for FDA. And I'm wondering what types of resources you think we need. We've heard others talking about CMS, but I'm wondering about FDA.
You know, I think the leadership at FDA has a pretty clear vision of some things that need to change, and they've done a pretty good job of articulating that through their strategic plan.
Great. They've also told us about it, too. Thank you very much. Thank you, Mr. Chairman.
Chair, thanks, gentlelady. I have a unanimous consent request. I'd like to insert a letter from the Lupus Foundation of America into the record. Without objection, so ordered. This has been another very informative and important hearing. Thank you very much for testifying today. We will have a lot of follow-up questions, I'm sure, from members. We'll send those to you. We ask that you please respond promptly. Members will have 10 business days to submit their questions for the record. That means they should submit their questions by the close of business on Tuesday, August the 5th. Without objection, the subcommittee is adjourned.